My name is David Kadara, and in this paper, we sought to understand mitigation strategies employed during COVID-19 to protect small and sick newborn care and inform solutions for resilience. We conducted multi-country qualitative research with small and sick newborn care health system actors in 4 African countries: Kenya, Nigeria, Malawi, and Tanzania. We identified mitigation strategies organized by 2 pathways. Pathway 1, COVID-19 infection responses with secondary benefit to small and sick newborn care, and Pathway 2, health system mitigation strategies and adaptations during the pandemic with secondary benefit to small and sick newborn care. The implications for investment and improvements include investment from governments across the health system to protect gains made and address gaps, which include developing an investment case for small and sick newborn care, support for family-centered care approaches, investing in information systems, community linkages to support post-discharge care, and investments in human resources for health for both numbers and scale risks.
Hello, I'm Dr. James Cross, a research fellow at LSHTM. Today, it's my pleasure to introduce our new publication titled Neonatal Inpatient Dataset for Small and Sick Newborn Care in Low and Middle Income Countries, Systematic Development and Multi-Country Operationalization with NEST360. Our publication details the collaborative creation and implementation of a core inpatient dataset in alignment with the goals of the Every Newborn Action Plan. The development process started with a review of existing neonatal ward data tools and datasets from high mortality settings. This review laid the foundation for our co-design phase, involving over 40 government policymakers, implementers, and clinicians. Through multi-stakeholder workshops, we streamlined an initial list of 300 variables down to a core set of 60. The dataset now has been successfully implemented in 69 units in 4 African countries and holds over 450,000 individual records. Ownership of the dataset rests with country governments and facilities, enhancing its utility through linkage with live QI dashboard and national level DHS2 servers. The dataset has now also become a global public good. This allows for its download, adoption, and usage today, enabling facilities or countries to measure the impact, coverage, and quality of level 2 care, expediting progress in reducing the annual 2.3 million neonatal deaths.
My name is Sarah Moelis-Collins, and we focused a paper on neonatal infection. Infections kill babies. We need to get better at detecting infections if we hope to reduce infection-related neonatal deaths. We designed a cross-sectional study which aimed to quantify the neonatal infection detection gap in 61 hospitals linked to NEST. Over 140,000 neonatal admission records were analysed. We found that while antibiotic use across hospitals was 70.4%, blood culture use was only 6.3%, emphasising an urgent need for improved detection and antibiotic stewardship. If we stratify this graph by country, we still see a major gap for each, but larger in Malawi, where most hospitals with NEST are district level, compared to majority secondary and tertiary level hospitals in remaining countries. Despite the marked underutilization of blood culture at the country level, we found stark hospital level variation, with some hospitals outperforming. The takeaway message is that we can learn from these outperforming hospitals, and it emphasizes the opportunity for cross-hospital and cross-country learning through partnerships.
Hi, my name is Becca Kirby, and for our target product profile paper, our focus was on the many life-saving newborn technologies that exist in high-income countries, but are not currently available in low and middle-income countries. One potential way of closing this gap in effective, affordable, and easy-to-use newborn technologies is by specifically designing new products for these settings. Target product profiles, or TPPs, are used to define unmet needs and help product manufacturers understand the key features of an innovation, including the desired characteristics. We used a Delphi-like process to develop 15 newborn TPPs, which UNICEF published in April 2020 and has since been viewed over 7,000 times. This approach was novel in scope, breadth, and reach, establishing a unique methodology to apply the TPP process to medical technologies for newborn care demonstrates the potential to replicate this approach for other global health burdens.
Lucky Manguilo, NEST360 Malawi Study Coordinator at Kamuzu University of Health Sciences. Most medical devices often fail in low-resource hospital settings because they cannot withstand the humidity, dust, frequent user turnover, complex maintenance, and erratic power sources. We have developed an 8-step process to identify medical devices that are reliable, affordable, light, and easy to use in order to enhance quality newborn care. Of 271 devices considered, only 23 products passed the evaluations. 2,457 devices were installed across 65 newborn wards in Tanzania, Malawi, Kenya, Nigeria, and a 99% uptime has been observed by continuous monitoring with minimal device failures. Our hope is that similar processes can be adapted and expanded beyond the care of newborns to benefit other low-resource settings. Join us in making a difference. Thank you.
Hi, my name is Josephine Langton, and in our education paper, we describe the feasibility and short-term outcomes of the approach used for development of national neonatal training with inclusion of medical devices. This unique approach included involvement of stakeholders throughout, inclusion of biomedical engineers and technicians within the healthcare team, emphasis on interprofessional education, development of adaptable educational materials, qualification of trainers through a generic instructors course, GIC, and use of a robust quality assurance process. Educational modules, scenarios, job aids, and videos have been published, with 2,962 downloads by June 2022. The inclusion of the biomedical team as a valued member of the healthcare team was novel and immensely successful in increasing awareness and respect for these cadres on both sides, but also in improving cross-cadre knowledge of maintenance and importance of medical devices in newborn care units. The GIC and its small group interdisciplinary approach have positively influenced neonatal care, biomed and medical relationships, and device maintenance, whilst the overall approach has ensured that high-quality interprofessional training is included within national agendas for neonatal care.
My name is Alice Sarus. On behalf of our interdisciplinary team of 16 authors from all over the world, we are excited to share a rapid overview of our paper. To save millions of newborn lives each year requires high-quality neonatal care with functional devices, fixtures, and trained healthcare professionals. However, there are gaps for these inputs and lack of publicly available tools to inform planning and costing. Together, our team systematically developed an open access tool to inform the number of devices and furniture needed and the cost for small and sick newborn neonatal level 2 care. We reviewed existing tools, then co-designed a new tool and refine it through national use in Tanzania. The tool incorporates furniture and device lists based on WHO guidelines, UNICEF manuals, and national policies. Unit costs were derived from government procurement agencies in Kenya, Nigeria, and Tanzania. The tool has 3 components: furniture and fixtures with 18 default but editable items, neonatal devices with 16 product categories, user training. The tool was practical to use, informing Tanzania procurement list and cost estimate for level 2 scale up in 171 hospitals. Please use this tool and help us improve. Thank you.
Hello, I'm Rose Kamoyo, and for our investment case paper, our aim was to develop a 5-step framework to be used in a low and middle income country and provide data-driven analysis to make a case for additional investment in small and sick newborn care. We did this analysis for Tanzania, and in our framework, first we reviewed the country policies and guidelines. Then we estimated the potential benefits of scaling up small and sick newborn care using the LifeSafe tool. Third, we estimated the cost of scaling up newborn care, after which we then calculated the return on investment, and finally identified potential financing opportunities. From our results, the returns are quite significant, with a potential return of between 8 and 12 for every dollar invested, and our proposed 5-step framework will be used by other countries wanting to accelerate progress.
Hi, my name is Rebecca Penzias, and I'm pleased to share a quick overview of this paper on behalf of our team. Many newborn deaths are preventable, and to save lives, hospitals must be ready to provide high-quality care. To meet global newborn targets, we need to know what health system ingredients hospitals have available, which is often assessed through health facility assessments, or HFAs. Some HFA tools measure wider service provision in obstetric care. However, there's a content gap where HFA tools did not comprehensively assess readiness for level 2 small and sick newborn care. To address this gap, NEST360 and UNICEF jointly led development of a new HFA tool. This tool was systematically co-designed with 4 country governments and reviewed by more than 150 multidisciplinary experts with a focus on feasibility. The HFA can be completed in just one day and is organized by adapted health system building blocks. The HFA tool and supporting materials are available online and can be adapted by other countries to assess readiness and track progress towards global newborn targets.